Welcome to today's Metro Carolina Trauma Advisory Committee month. Awesome. Today's topic is red flags and recognition of abuse. Our speaker today is Dr. Kendra Ham. She has an extensive experience in this area, and it obviously has a career commitment to child abuse. Far back prior to coming to Atrium, she was at the Medical University of South Carolina in Charleston, was the director of the Child Abuse Pediatrics Division, and then since here is now at Atrium, also the site medical director for the child protection team here at Atrium Health. Pediatrics and particularly pediatric trauma is always a very hot topic across the region. And NAT has been a significant issue and continues to be, specifically some of the issues that we had discussed last year regarding some of the COVID-related issues. So anyway, a timely topic, and unfortunately, it seems to never go out of interest and importance. So Dr. Ham, take it away. Thank you.
Thank you so much for that wonderful introduction, Dr. Singh. And welcome, everybody. I know this can be an incredibly difficult topic, but hopefully it'll be very educational for you. So we do have several objectives that I'll hopefully get through in this very short talk of over an hour. But I want to start with just some recent statistics for the U.S. and child abuse and neglect. We will discuss recognition of signs and symptoms that are concerning, particularly for physical abuse for this talk. Sexual abuse and neglect, I'll have to save for another time. We will be able to define sentinel injuries and understand their importance during a workup. We'll review the guidelines for skeletal surveys, and we'll also discuss the importance of very clear and appropriate documentation in the workup of these cases, and we'll learn how to properly photograph injuries as part of your documentation. I have no disclosures. So I usually like to start with a case just to kind of give you some background on some of the things that I do see on a day-to-day basis. So this is actually a case that I had in fellowship, but it was a 4-week-old male that was seen at an outside hospital ED that had a reported 3-day history of fussiness and a 1-day history of eye redness. He was brought in by his mom at the time. The ED provider saw him and diagnosed him with bilateral subconjunctival hemorrhages, constipation, and colic, and the recommendation was supportive care with a discharge home to mother. So this child actually already had a scheduled appointment with his PCP for his 1-month well check just 4 days after his ED visit. So he went to the PCP's office for that well visit. PCP very astutely referred him back to the ED for an NAT evaluation because she was so concerned. On exam at the hospital, he was seen to have, again, these bilateral perilimbal subconjunctival hemorrhages. He didn't have any other bruising or other findings. And when they asked mom some additional history, she said that the baby had had a slight cough, but was otherwise well, and she actually denied any constipation at that time. So here's a picture of the subconjunctival hemorrhages, both of his eyes. I zoomed in so that you wouldn't see his face, we wouldn't identify him, but pretty significant hemorrhages. And this is now 4 days after he was initially seen at that outside hospital ED. And of course, everybody was really concerned when they saw this. And typically, babies at this age cannot produce the intrathoracic force or intra-abdominal force that would create this kind of hemorrhage as a result of coughing or constipation or straining with stools, which is what concerned everybody about this. So he ended up getting an NAT workup just because everyone was so concerned. He had screening labs that were normal. Head CT was normal without intracranial findings. His skeletal survey was normal. Ophthalmology was consulted, and they did not see any retinal hemorrhages, which sometimes we can see with these evaluations. They only just, again, saw these bilateral subconjunctival hemorrhages. I got involved along with my attending at the time, and we didn't see any other findings of abuse, but we're still concerned. So he ended up being discharged home with PCP follow-up with us in a couple of weeks for a follow-up skeletal survey. Of course, they missed their 2-week follow-up appointment. There were no-shows. Finally, we saw them 3 weeks later and had the follow-up skeletal survey that had 4 healing rib fractures that were not initially seen on the skeletal survey that he had in the hospital. So he ended up being readmitted to the hospital from clinic with a diagnosis of physical abuse. And I actually circled the one that I think most people will be able to see if they're looking at an x-ray. We see this callus formation, but again, he had 4 healing rib fractures. And sometimes it can be really difficult to see the fractures in the acute phase in these infants when they're so small. And usually when they're healing, they're a lot easier to see. So when he was admitted again, we ended up getting an MRI of the brain just to see, just in case we missed something with that initial head CT, but it was negative. DSS was involved and he was placed in protective custody for the rest of the investigation. Law enforcement ended up interrogating mom, and she reported that she had gotten frustrated with the baby because he was so fussy at night. She held him out in front with her hands and squeezed and shook him back and forth. And she said that she did this about 11 hours prior to noticing the hemorrhages. And what was really concerning for us is that, initially this could have totally been missed. This baby could have come back with even worse injuries if he hadn't been seen by his PCP just a few days later after that ED visit. So why is that so important? I think it's important to discuss statistics. There are a lot of people that still don't want to think that child abuse exists or happens, but it most definitely does, and it's really important to recognize it. But it helps to know some background statistics as well. So I usually get my statistics from the National Child Abuse and Neglect Data System. Unfortunately, they're always a couple of years behind, and the most recent data that we have are from 2020, everybody's favorite year of your life. We always love to revisit that, but we'll have to revisit it just for a few minutes for these statistics. So there are always over 3 million children who receive some type of child protective services investigation response or alternative response. All of those kids don't always necessarily end up with a diagnosis of abuse, but some of them might just need extra services. Maybe the family doesn't have resources to feed them, things like that. But the total number of victims, a rounded number of victims in 2020 for abuse was 618,000. And that did decrease from 2019. And we definitely have some reasons why that might be, just because kids were not presenting to care. People were afraid to even go to the ED for things that they would normally go to the ED every day. There were also fatalities from abuse and neglect, and this happens every year. That number did decrease just slightly in 2020 with about 1,750, but we don't always know the exact number of that. So this graph actually shows you who is more likely to make these reports to Child Protective Services, which we call DSS in North Carolina and South Carolina. Usually the education personnel, so your teachers, principals, guidance counselors, school social workers are usually the most commonly reportable people for these types of issues. And, medical personnel are in there too, but pre-COVID, when kids were in school, most of the reports were coming from some type of school or daycare. And then we normally see this huge drop because kids aren't in school in the summertime. However, if you look towards the COVID-19 lockdown focus period, somewhere around March to April, June, that number completely decreased almost to nothing, even towards the end of the year, because kids were at home. And we know, and I know for sure, once kids were back in school, our numbers skyrocketed in clinic, and we were actually having a hard time keeping up with the numbers of cases that we were seeing. So the most common type of maltreatment that we actually see is neglect, even though you might not see it in the hospital setting. And then physical abuse makes up about 16% of those cases, sexual abuse about 9%. Human trafficking is less than 1%. There are some places that will include human trafficking within sexual abuse, so you might see that, but the majority of cases are from neglect. So who are the victims? Males and females have approximately the same rate, with females being 8.9 per thousand children and males being 7.9 per thousand children. And unfortunately, there are health disparities with this, with Alaska Native and American Indian having the highest victimization rate and African Americans having the second highest rate. And this is again from the NCANS data. Fatalities, we know that children under the age of 1 year are most likely to be abused and most vulnerable, and they make up about 46% of all fatalities from abuse, which is pretty significant. So if you are an EMT and you're going to a house, or if you are a surgeon in the OR, it's important to know this statistic as well. And then perpetrators, the majority of the perpetrators are apparent to the victim. Now, this data set does not stratify if it's a step parent versus biological parent. There are some parents that have boyfriends, girlfriends that call themselves parents as well, but usually it's apparent to the victim. And as you can see from this graph, the children that are under a year of age are the most vulnerable and have the highest rate compared to all the other ages under 18. So let's discuss some red flags for physical abuse. I have another case for you. This is a 2-month-old male that was sent from his pediatrician for bruising from playing. Now, if you think about what 2-month-olds can do, they usually can't do too much. They might coo, they might smile, they're not rolling, they're not walking, they're not cracking jokes with you, they're not really doing too much of anything. But they said that this happened while he was playing. The family gets very upset in the ED because pediatricians sent them there and said they needed to be admitted. Once they're admitted and they start to get the workup, the family is able to calm down on the floor and they present it with a quote unquote plausible mechanism of injury, something about mom was walking down the stairs and accidentally bumped into the corner of the wall, and maybe that's what happened. Well, why is this concerning? So there's this landmark article, I know it's old, from 1999. We still use this article in court all the time. If you've not heard of it, I'm happy to share the reference with you. But they looked at children under the age of 3 years that were being seen for well visits at their PCP's offices. And they wanted to look at the frequency of bruises based on age group. And they noticed that the frequency of bruises increases with age, usually with infants having very few or none, all the way up to these toddler ages that will have multiple in multiple different areas. And also what they saw was that bruises on the forehead and the upper leg were very common among the kids that could walk, but bruises on the face and trunk were very rare. Bruises on the hands and buttocks were not observed at all. They followed this up a few years later in 2014 to try to determine the prevalence of additional injuries if a child presents with an apparent isolated bruise, or also to determine the prevalence of bleeding disorder in infants with isolated bruises. So they looked at infants that were less than 6 months of age that apparently had isolated bruises. A little over 50% of those were screened further. However, 23% of those had a new injury on skeletal survey, which means they had some type of fracture. 27% had new injury on neuroimaging, so they might have had intracranial hemorrhage or a skull fracture. And then a little less than 3% had abdominal injury, which is really concerning because abdominal injuries can be very easy to miss, but they can be very quickly fatal depending on what's going on. And a whopping 0% had no bleeding disorders whatsoever, and the majority underwent testing. And a lot of caregivers would like to tell you that, oh, my kid bruises easily. What exactly does that mean? Usually kids will have bruises. It does not mean that they bruise easily. It just means that they like to play, and it's normal to have some bruises at certain ages. So you might have heard of the 10-4 faces P mnemonic, and if you haven't, you'll learn about it now. It started off with 10-4, then it became 10-4 faces, then it became 10-4 faces P, and I feel like they might still keep adding some more letters and numbers here. But the 10 is the T is torso, including the genitals. So, when kids come to the ED, it's very easy to forget about the genitalia, but you might be missing a very important injury in that area just from not looking. The ears is very unusual place to have bruising. The neck, also very unusual. The 4, and it's not on this slide, but 4 is any bruising in a child less than 4 months of age, or any of these areas is concerning for a child that's 4 or younger. The F is for frenulum, which you can see from forcing a bottle into a child's mouth or an infant's mouth. It is possible for a toddler to have a frenulum tear if they take off running full speed, they run into the coffee table, they have a busted lip, and they have that good story that explains that injury, but it's otherwise unusual to have a frenulum tear. The A is for angle of the mandible. Very unusual to see a child fall and bruise their mandible area. That's usually from being grabbed by an adult or caregiver. The cheek. So the C is cheek, the fleshy part of the cheek in particular. It's very unusual to see bruises. E is for eyelid. S is for scleral or subconjunctival hemorrhage. And then P is for pattern bruising. So remember that clumsy baby that was playing and got a bruise on his face at the age of 2 months. Now it's 3 months later. He is 5 months old and he has supposedly rolled over and now will not move his right leg. And then also parents say he hit his head really hard on the crib a couple weeks ago, and all of a sudden he wouldn't bear weight on his right leg 2 days after that. Comes to the hospital, ends up with left-sided subdural hemorrhage, right-sided parietal skull fracture, right tibia fracture. Be very aware of stories that don't fit the injury. Be very unusual for a 5-month-old to roll over in the crib and fracture their own skull. Very unusual for them to roll and fracture their own tibia, etc. So this kid ended up coming back with more injuries. So beware of abusive head trauma. Sometimes we'll see subdural hemorrhages, skull fractures. They can have associated injuries like rib fractures or corner fractures like you see down in the diagram here. And we also look for retinal hemorrhages with our wonderful ophthalmologists that help us with these workups. But always be aware of stories that don't fit the injury because they will likely need further workup. And just a little plug on abusive head trauma. We don't call it shaken baby syndrome anymore, although you'll still hear a lot of people in the literature and a lot of people in medicine in general still call it that because most people understand what that means. However, we call it abusive head trauma just because if you call it shaken baby syndrome, that implies that there's only one mechanism, i.e. shaking. And I've actually had a caregiver tell me that they picked up a baby and slammed them multiple times on the bed. So it's not really shaking, they were being slammed, but it caused those same injuries. It does not require impact, but there can be impact. We can see associated spinal cord injuries with those. And typically, if we're getting an MRI of the head, we will also get an MRI of the cervical spine to look for those ligamentous injuries that might give us an idea if there's some type of whiplash injury. It's more common in children under the age of a year. Unfortunately, it's 5 times more likely to be fatal than accidental head trauma, and it's the leading cause of infant homicide in the US. So remember we were talking about these frenulum tears. So this is not the baby that I saw, but I did have a 2-week-old that presented with this very finding. And dad only brought him to the ED because he saw a little bit of blood in his mouth and noticeably got upset, understandably got upset, brought mom with him. There was absolutely no story whatsoever. I ended up doing a consult on this kid. He had no other injuries whatsoever. But when law enforcement got there, mom actually admitted to shoving the bottle in his mouth because he wouldn't take it very well for her. But again, it seems like such a small injury, but it means so much more. So that would be an example of a sentinel injury. So if you've never heard of that before, it's a seemingly minor injury in a pre-cruising infant. So cruising meaning like when they can stand up and they're walking along some furniture. That's poorly explained and therefore very concerning for child physical abuse. There's been so many articles written on sentinel or missed injuries since that article, just because it's so concerning and these kids can come back with worse injuries later if they're missed. In the Sheets article, they saw that infants that came in with an abuse diagnosis, 27.5% of those had a prior sentinel injury. So they'd already presented to medical care. They had a bruise or an intraoral injury or a fracture, and they came back with even worse injuries with a diagnosis of abuse. In the oral study, They saw that 30% of abusive head trauma cases had the diagnosis initially missed by medical staff. Those included kids that had femur fractures, rib fractures, or persistent vomiting. 19% of child fatalities were seen in non-well child visits in the month before they died, which is really scary. So if you're a pediatrician and you're seeing these patients, nobody ever wants to hear they just saw somebody and they died a few weeks later. In the Dean study, they deducted that increased mortality, there's higher mortality in traumatic brain injuries from non-accidental trauma than accidental. So if there's abusive head trauma, it's way more likely to be fatal. And then in the Jenny and oral studies, they saw that the majority of abusive head trauma can actually be prevented by earlier recognition, which is the whole point of this talk today. So remember our friend with the subconjunctival hemorrhages. I was thinking truly, because we have so many patients that this happens to, parents do not follow instructions to go to their well child visits. They end up missing months and months of visits. If this child had not had a visit with his pediatrician just a few days after the ED, something worse could have happened to him. Mom could have shaken him again. He could have come back with subdurals or other findings. He could have actually died, which is very important to make sure that we recognize the red flags. The case of the hidden diagnosis. So this is a 12-month-old male that came in with a history of reactive airway disease that was brought in by EMS for wheezing. He was found to be hypotensive with undetectable oxygen saturations, was in shock with a hemoglobin of 5. So the ED starts to transfuse him, and all of a sudden he has abdominal distension and bruising. Occult abdominal trauma is very scary, like I said earlier. Sometimes, well, for the majority of the kids, they don't have findings on their abdomen. They won't have bruising. They won't have abdominal distension to give you some kind of idea that something has happened. However, one thing that you can do is get your trauma screening labs, including your liver function enzymes. Now, this is something that the surgeons like to argue with me about, and I totally understand why. But in the child abuse literature, the magic number for the AST and ALT is 80, which should lead you down the path of abdominal CT. Now, most people want to do a FAST, which is fine, but it's not necessarily diagnostic. But that's the lowest number that they've been able to detect an intra-abdominal injury in the child abuse literature. With some of these being occult, so you don't know until you go looking for it. It might not change your management. It might not mean that you have to do surgery in the abdomen, but it does change charges. It does change DSS's recommendations, and if they substantiate a case or not. The more injuries that a child has, the more charges the caregiver might obtain. So it is still important to make sure that we're not missing anything. And then also just the fact that abdominal trauma is the second leading cause of death in abused children. So let's go through some radiographic red flags. Anytime you don't have a story, that's always concerning. So this is an 8-week-old male that I just had recently with a spiral humerus fracture. Now, it used to be that people would say spiral fractures were pathognomonic for abuse, but that's not necessarily true anymore. We do know that they can happen accidentally, but they should be able to give you a good story. The story that we received was maybe he did it himself when he was moving his arms around. Also got another story when we told him that could not be. They said maybe it happened when he was taken out of the car seat. But again, no story, and none of that really made sense. Skeletal surveys. People tend to get up in arms when they come in the hospital and they hear their child has to have all of this radiation, but there's definitely an important reason for that. Kids can't tell us if something hurts or if something hurt 3 weeks ago that we might miss. So it's very important to get this done. We really prefer for skeletal surveys to be completed where a pediatric radiologist can read them. That is not a requirement, it's just a preference. Some places don't have a pediatric radiologist, but they do really good images and they have great quality. However, we have had some kids that have been referred from outside facilities where they don't have enough imaging. We're having to repeat it because the quality is not great. And then the parents are even more upset because are having to get more x-rays. And some sites just don't obtain the recommended number of images that we really need and based on protocol. So this x-ray to your right is not a skeletal survey. And I haven't seen one of these in a while, but occasionally they do pop up and they get billed as a skeletal survey at the outside hospital, but they're not really. And so we have to repeat the whole thing. But it's actually about 21 images, 22 images. So it ends up being a lot, but our teams are great about making sure that they use the least amount of radiation as possible. But we have to get all of these views that you see listed in this chart, especially those oblique ribs that I see a lot of facilities forgetting to include to help us see if there are rib fractures. So we're going to talk about some fractures with high specificity for abuse. Long bone fractures in children that are not ambulatory have high specificity. They should have an impeccable story for me to believe that they just rolled off the bed and caused this. A lot of times we see babies that have rolled off the bed. Nobody heard it. Nobody saw it. They just said they were on the bed and then they weren't. So they can't really tell you how it happened. Absolutely, they need a workup. Transphysial or transphysial distal humerus fractures. You might hear the orthopedic surgeons call it epiphyseal separations. It's usually a displaced Salter-Harris type 1 fracture of the distal humeral physis. It can be really difficult to diagnose on x-ray until you see the signs of healing. So on the right, you see signs of healing. On the left, I don't know that I'd be able to diagnose that. Classic metaphyseal lesions. So I tend to see these just in regular physical abuse cases, sometimes in abusive head trauma cases. They have different names just based on the appearance on x-ray. And I wish they hadn't called it a lesion because people hear lesion and they think it's not a fracture, but it is a fracture. So this picture on the left, this x-ray, you can kind of see this faint white line that's going around the bone. It almost looks like there is a bucket handle or handle of a bucket, and that's why it's called a bucket handle fracture. That same fracture, though, in a different view, looks like a corner of the bone has come off, so it's called a corner fracture. Same thing over here. Some people will call this a chip fracture over here on the right, but all the same mechanism essentially was very forceful jerking, yanking of the extremity. Sometimes when babies are being shaken back and forth and their arms and legs are flailing very forcefully, that can cause one of these fractures. It can happen iatrogenically. We've seen this when ortho's doing clubfoot repair and they're having to forcefully manipulate the extremity, or in difficult breech deliveries when the OB is really just trying to get that baby out and they're yanking very forcefully to get the baby to save both the baby and mom, and you can cause that fracture then as well. Rib fractures, you can see them circled over here on the right. Rib fractures can happen in CPR. We know this for a fact, but without that history of the baby getting CPR, that really should increase your suspicion. Even if they are getting CPR, it does not mean that that happened then. It could have happened prior to the CPR when they were at home, but they have high specificity. Some other fractures that we don't see very often, unless there is some very traumatic MVC or serious abuse, are sternum fractures, scapular fractures, and pelvic fractures. If they haven't had a history of major trauma, that should really raise a red flag and they need to do an additional workup. Kids with multiple fractures, especially in various stages of healing, if they have bilateral symmetrical fractures, like this baby here, who was getting a diaper changed and the caregiver got very frustrated. Fractures associated with other injuries, all those will have high specificity. So let's talk a little bit about documentation and what not to do. So here's just a little soapbox of mine. I'm on a listserv with all the other child abuse pediatricians in the US. And some people have had trouble when they have talked about NAT or non-accidental trauma. And there are some defense attorneys that are kind of latching onto that. And when they say, If you call something non-accidental trauma, you're saying it was not an accident. How can you tell me that my client didn't do this accidentally? Like, they really latch on to semantics, and that truly is not the important part of that court proceeding. However, there have been some courtrooms where you can't even use the word NAT or non-accidental trauma. They make you say something else. They just tell you you can't say that for the rest of the time that we're in here, which is really annoying, especially when it's all over the documentation. But normally, I like to say there's concern for physical abuse or concern for inflicted trauma, not trying to say if it was an accident or not. Most people are not trying to hurt their baby or not trying to kill their baby. So trying to say that it was an accident or not kind of throws a wrench in some things. I've not actually seen an ICD-10 code for non-accidental trauma. They make you come up with something that's more specific, which is more recommended anyway, especially if you're trying to do research and looking for different diagnoses, but no one's using that specific diagnosis. Be very aware of when you're documenting that a family is appropriate. I don't think that we ever talk about a family being appropriate if they're coming in for asthma or seizures or any other type of general pediatrics issue. It's only in these workups that people feel like they need to say that a family is appropriate. And the problem with that is you might be forming your decision based on bias and thinking that the family is so nice. But I can tell you for a fact that I've had some very nice caregivers that end up confessing to law enforcement later that they did something. So we don't ever want to base our reasoning for a workup based on the appropriateness of a family. Don't assume that the person is the mother or father. I have had one case actually that everybody kept documenting that the lady was mom. Mom brings this baby in for this, this, and this. And then when I met her, I said, "So you're a mom?" She said, "No, I'm the aunt. Mom is on drugs and we don't know where she is." And we're like, "Oh, okay. So who was mom actually here? Was it actually just aunt that was giving this history?" And people didn't ask her who she was. It's very important, again, just to know who you're talking to. Again, also for court proceedings, please help me out with this because they like to keep me on the stand for quote unquote mistakes in people's documentation and totally forget why we're in the courtroom to begin with, but I just get stuck on there having to discuss why that wasn't a mistake or something. It's not really fun. Be careful also with copy and paste if you did not get that history, because it is possible that someone had a typo or they misheard someone, and then it looks like the caregivers are giving different stories, but that's not even the story that they gave, but then it just gets copied and pasted in each person's notes because it's not the history that you obtained. For any EMTs that are on this call, thank you so much for everything that you do, because I know that there are times when you go into houses that look like this, and I find it very helpful. Actually, all of us too find it very helpful when you document what you see. We have no idea about the environment that this child has lived in unless it's written down somewhere. And I have found some of the EMS run sheets to be incredibly helpful as well. One in particular where no one in the hospital had documented that a baby had a bruise, but the EMT put it in the run sheet that this baby had a bruise when they went out to the house. So prior to any resuscitation, prior to presenting to the ED, prior to coming into the PICU, and it was incredibly helpful. So if you see anything that looks like this, please put that in your documentation as well. So other things that you should document, just any observations. Sometimes the ED will document that a caregiver appears to be intoxicated or they smell like weed. Anything that makes us worried about this child's safety, everything that we can learn about this family will help them and will help us in discussing with DSS so they can make sure the child is safe when they get discharged home. Document any physical findings that you see that are concerning. Don't just rely on your photos for that. If the caregiver or child talks to you and gives you a history, put what they say in quotes. Don't just summarize or paraphrase. Try not to use words that they didn't use. And again, for EMS, if you notice caregivers' behavior when you first go out to a scene, that can be really helpful. If you see drug paraphernalia, that might lead us to want to order a UDS on a baby, and any findings that you immediately see. And for everyone, make sure you're documenting any pattern injuries that you see and think about what that pattern might be. You don't necessarily have to diagnose physical abuse, but you can just say that it's concerning for a particular object. Photography. So one great thing about our EMR is that we can take photos and we don't have to use our personal cell phones and save it to our iCloud, but it goes directly into the patient's chart. I'm not sure about EMTs being able to take photos. You might leave that to law enforcement if they come to the scene with you. But one very important thing about taking a photo is making sure that we can see what body part we're looking at. So look at this and try to think about what body part this might be. And if there are any context clues whatsoever that tell you what this body part is. You might have trouble unless I told you, but this is a child's neck. I've had people say it looks like maybe the back of the leg, the back of the arm, maybe the inner arm. And I've seen some documentation where they just take the picture, which is great, but they don't document the physical findings in their own words. And I've had kids that have been referred to us outpatient, and we have to rely on DSS getting these records. They print these records off in black and white, and then you have no idea what you're looking at because it wasn't actually in the written documentation. There's just some black and white faded picture of it. So it's really important to make sure that you zoom out so you can see exactly what body part we're in, and then you can zoom in. It's important to have good lighting. Don't just rely on the photo itself. Describe exactly what you see. Sometimes what you see with your eye looks different in the photos depending on the lighting and shadows. The photos should not just be the only description that you have in your note. I like to use this measuring device that you see, this ABFO ruler here. You don't have to use that. You can use a tape measure. I've even seen people use a coin. A penny never changes its size. A quarter never changes its size. If you don't have anything else, you can put that coin next to that injury and we'll always be able to figure out how big it was. Make sure we're able to identify the patient. Before and after photos are important, especially if, EMS is picking up this kid and they're completely filthy. I had actually had a kid that I saw that was completely filthy, just dirty from head to toe. The soles of her feet were black. She had fleas. They took it before a picture, and then the nurses got there and bathed her, and she looked completely different after that bath. But those pictures were used in court, and it's very helpful to see this is what this child looked like before they presented to medical care compared to when they got medical care and someone actually gave them a bath, and then they looked like this. It seems to really resonate with the judge, the jury, when they think about what kind of environment this child was in. So if you're using Cerner or Epic, make sure you embed that picture in your note. I learned, unfortunately, with Cerner that pictures in the media tab go away after 2 years. So there is a court case I have that is 2.5 years behind, and now we can't get to those photos that we're taking in Cerner, unfortunately, because they weren't embedded in the note. Make sure you're using your app only and not your personal phone. And I would definitely recommend avoiding anogenital photos in the EMR. It's just a very private area of the body. And you don't want that to be something that people see every single time they open your note. So again, another example of a picture. It's better than that last one. We have some landmarks. We see an ear. It's definitely the left side of the face. We see part of the eye, but we also see this pattern injury. So this is a slap mark, very highly concerning and suspicious, and would likely be considered diagnostic of physical abuse. Here's just a random picture I got from the HuffPost online. When you leave kids to their own devices and don't pay attention to them for probably only 3 minutes. And here are my references. I know we have some time for questions. I wanted to make sure I'll have time for that. I can see if I can try to look at the chat, but.
Dr. Ham, that was tremendous. I've been here doing trauma, and we obviously cover all the pediatric resuscitations for many years. Won't even go into the numbers. We deal with NAT situations and questions all the time, and I've heard a number of presentations through the years. I think that was really the most comprehensive and probably easily understandable presentation on this topic, which is a remarkably important topic. I want to thank you very much. I was trying to think about some questions, but because I've actually always had questions about this topic, but you kind of hit on every one of my questions along the presentation. So I'm not quite sure what to go through next. The only thing I would say regarding our experience here is that, we obviously, because we're on the adult side most of the time, after the resuscitations, we're transferring over to the pediatric side and having the CHIPS team, and they've been doing just such an excellent job with following up on these. I guess from your experience here with us in emergency medicine, the trauma service as well as emergency medicine, do you see any, have you seen any major gaps or areas that we could potentially improve upon with this topic?
I haven't really. I think everybody's been following the protocols pretty easily. Just occasionally I'll see some missing labs, but that's easily rectifiable. Usually it's the coags. We're looking at PT, PTT. I think just because the way the order comes up in the system, it's just PT and INR, and then people forget about PTT, especially for kids with bruising. That's probably one of the main things that I tend to see.
Hey, Kendra, it's Laura Newman.
Yes.
If I could add to that, and I'm sorry, I was at a different meeting, but the one thing I do see coming out of the ER and the trauma that I tell our same pediatric interns and family medicine is to avoid with that first encounter putting statements like, it couldn't have happened that way into the note. Because very often we find out with a scene reenactment with more investigation that sometimes some weird things do happen. You just say it couldn't have happened that way and you don't put any other information, then it's a very incomplete note. So I would avoid that until you have more information, the scene investigation, if there's one, that sort of thing.
Right.
That would be my recommendation for some of the junior level intern and resident notes that I'm seeing.
We have a couple of hands up here. We have Dr. May.
Hey, thank you, Ron. Want to echo Ron's input about the quality of the lecture. Excellent lecture. Very helpful. Learned a lot. I do think that it is, for us, very helpful to have a highly skilled pediatric emergency department that I think with involvement of multiple parties help us identify, I think, the infants and young children at risk pretty well. I just wanted to, could you repeat the terms that you prefer to be used instead of non-accidental trauma? Because I for sure have been not doing the best documentation.
And that's totally okay. I think we'll never completely get away from saying NAT, but if you could say, injuries concerning for physical abuse, I think most people understand what that means compared to just NAT. You could even say concerning for inflicted trauma. It's not implying if it's an accident or if they meant to do it, it's just inflicted, but physical abuse or inflicted.
Great, thank you.
You're welcome.
That is very helpful. I see a question, Dr. Evans.
Yeah, I actually was going in the same direction and had thought about it as CIT and think that we will continue to fail and call it non-accidental trauma until we create a process where all of our documentation. I mean, I am sure we have this in guidelines, we have this in, so if we decide to create an intentional process where we pick the term that we want to use, I liked the concern for inflicted trauma, or I thought maybe at one point you said induced, but that might be a good option.
Yes, I agree.
I also see Megan Waddell's hand up.
So in the chat, there was a question about documenting low suspicion for abuse. I know when I worked with Mary Clyde Pierce, Dr. Mary Clyde Pierce on the TQIP best practice guidelines for abuse, her recommendation was to not document that unless you were a child abuse pediatrician. Is that your recommendation as well?
Yes, I would be really careful about saying that, especially if you've not gotten the entire workup. So I've seen in the ED where they say low suspicion, but then they still admit them for a workup. And so that does concern families, and it confuses them when they, automatically get our notes now when we document. But if you say low suspicion after the whole workup has been done, I think that's okay. It's just, that initial, they've only had one X-ray and people are saying low suspicion, but then they get this full workup after that.
I had one other question. In working with Pediatric Trauma Society, we were looking at some different tools that would help diagnose child abuse related to burn injuries. Do you recommend using the burn tool? Is that something that you use? I think that was out of Australia from Dr. Kemp.
I haven't used it in a long time. I think it's fine to use it. And unfortunately, since, a lot of our burns get shipped out elsewhere, I feel like I knock on wood because I'm on consult today. I don't see very many burns as I used to.
I see Dr. Nina Cohen's hand up.
Thank you, Dr. Ham. I'm one of the acute care surgery fellows this year. This was an excellent talk, as everyone has said. My question is about any guidance or recommendation you have about the way that we, the verbiage we use with the family or caregivers with the children when we're evaluating them. It's usually a surprise to them when the trauma surgeon comes in the room to see their little kid that they didn't think had any trauma. And so sometimes we're at the beginning of when that evaluation is happening for their entire workup. And so any guidance you have for that? Thank you.
Yeah. Yeah, that's never great when you walk into the room and they haven't heard it from somebody else, and now all of a sudden you have to give that whole spiel. But I like to say, for certain injuries, it makes us more worried that something has happened to a child. We're not saying that you have done something necessarily to your child, but it's really important to make sure that we do the full workup to make sure your child is healthy and they don't have any other associated injuries. Even if you word it that way, sometimes they'll still say, oh, somebody accused me of abuse. It's like, it doesn't matter if you word it perfectly or not. They'll still hear what they think they heard or what they want to hear. But if you kind of word it that way and then also say it's hospital protocol, I like to throw that out there as well, that we work children up that have injuries such as this. Does that help?
Yeah, that's great. Thank you.
Scott Wilson, still your hand up there. Have a question, Scott?
Yes, and to kind of tag on to a chat comment that says that if we are slightly unsure about the type of injury, would it be better to just describe rather than state what we think it is? And tied to that,
yeah.
And tied to that also, I've noticed that with pre-hospital, you mentioned how crucial their documentation is, but there's at times hesitance to write certain things down for fear of liability or what if I'm wrong? Can you speak any to that?
Right. Really just document what you see. I don't think you'll be wrong about what you see. Try not to put your own opinions on it. I wouldn't say, instead of like parent very angry, maybe say parent yelling. Think like just whatever you actually observe. If the house has drug paraphernalia, I'm not sure that you would get in trouble for that if that's what you see when you go in there, because you're also putting your life at risk if there are needles lying around. Because we know that happens a lot here in the South. So really just say what you see, but try not to put your own physical opinion on it. Hopefully that answers the question.
Yeah, I always think that the best way, it's sort of like having a discussion with a family of try to make your documentation sound like a third party observer, that you're looking down on the situation, therefore you have less actually input and just truly just be objective as possible.
Yes, I agree.
I don't, Dr. Evans, still have your hand up. You have another question?
No, sorry.
That's right. Well, listen, Dr. Ham, again, that was really tremendous. I enjoyed that very much. And if you're not clear on the Metro Atlanta Trauma Advisory Committee, basically we're the trauma system. We're the regional trauma system, which is not just Atrium Health here, but 6 other level 3 trauma centers and essentially every emergency department, freestanding emergency department within the region for several multiple miles in many directions. So we have a fairly large catchment area. And if okay with you, I'd like to try to get the word out for people who haven't heard this talk, maybe get to you and hear this again. I think this was really a tremendous presentation. I want to thank you for your time today.
Thank
and
you so much.
expertise.
Thank you for having me.
Any other questions from the audience there? All right, great. I think we'll sign off right now. And again, Dr. Ham, thank you very much. That was tremendous.
Thank you.